HESC 114, Intro to Pharmacology, Chapter 4, Gastrointestinal Drugs, Part 2. All right, so those were drugs in the upper GI system. So again, the upper GI system, we're treating GERD and ulcers, we're treating nausea and vomiting. Those are the two really main components that we were talking about in the upper GI. Now we're moving down to the lower GI. The lower GI is taking into account your intestines, your small intestine. It has three areas. You've got the duodenum, the jejunum, which is the middle part, and then the ileum, which is the end part, and then you have your large intestine where the small intestine and large intestine meet. That's known as the cecum. Then you've got the ascending colon, the transverse colon, and then you've got the descending colon. And the last section is called the sigmoid, which means S-shaped. And then that goes into the rectum and the anus. So we're going to talk about things that are impacting your intestines. So one of the conditions is inflammatory bowel disease, often referred to as IBD. There's actually primarily two components. You have Crohn's disease and you have ulcerative colitis. They have very similar symptoms and treatments. Even though we don't know the cause, we do believe it to be autoimmune. So when we talk about the drugs, we're going to talk about steroids, which are anti-inflammatory. This is inflammatory bowel disease. We're going to talk about interleukin inhibitors, selective adhesion molecule inhibitors. I know some of these names are really, really long. We'll try to come up with some things with that. And then TNF blockers, tumor necrosing factor blockers. Most of these, the interleukins, the adhesion molecule inhibitors, and the TNF drugs, those are biological response modifiers. Those are immunomodulators. Those are bioengineered drugs. And most of your biological drugs are going to be stored under refrigeration. Most are going to be through injection, many IV. And the other thing is they're very costly. So we want to make sure that we're handling them properly and we're dosing them properly. So first off are your corticosteroids. So we use steroids for lots of different things. And here we're using it for inflammation in the bowel. So it's a glucocorticoid. So we've got a glucorter and the muscles for the steroid kind of thing, just as a little visual. But again, their main component is that they act as an anti-inflammatory drug. So they have a very powerful anti-inflammatory effect. They can be administered through many different routes of administration. They could be oral, but when we're talking about getting them to work in the GI system, especially that lower GI system, we may use a rectal administration, like a foam, an enema, or a suppository, but it can also be given by injection. So here I've got an image. This is hydrocortisone. All of these products are hydrocortisone. Brand names: Colocort, it's for the colon, it's a corticosteroid. Hydrocortisone, we're getting all those quarts kind of together. And this is an enema. And then we have over here Cordenema. It's got enema in the name, and it's telling you it's a steroid. It's a corticosteroid, and it's given enema. And then over here we have the brand name Cortef. So it took part of the cortisone, hydrocortisone name, and put that in the brand name. Now, when we are learning corticosteroids, they have different drug endings, and there's multiples. And they could be, here we're seeing cortisone, so it ends in zone. It could end in solone, like prednisolone, or cyanide, like budesonide. So if you're looking at the list in your book, you're going to see some of these other drug stems. Identifying a drug stem says, oh, it's a steroid. What do steroids do? They block inflammation. Now, what ones do what, where in the body, that's something else. But again, do we get the major comprehension of what's going on? Hydrocortisone was the first one that was discovered as an exogenous or a drug. So it is what we consider to be the prototype. So that's why I used it as the example on your drug list and here on this slide. Next, we have interleukin inhibitor drugs. Now, interleukin is actually a chemical in our bodies. There's an inflammatory substance called interleukin 12 and interleukin 23 in the intestines. This drug is going to block those interleukins. It's going to prevent them from activating our own natural response cells that cause inflammation. So killer T cells or natural killer cells and TNF cells. So the drug that they have identified in your book is known as a monoclonal antibody drug. It ends in MAB. This is a biologic drug, and the drug is ustekinumab, which is Stelara. So ustekinumab, that's kind of a mouthful, but Stelara, the brand name, we see that with a little trademark, right? Remember? That little trademark helps identify this is the brand name, and then the name underneath is the generic, and we're using that drug stem MAB. Now, MAB is not going to tell us it's specifically an interleukin inhibitor, but what it does tell us is it's a monoclonal antibody, which means that it's going to block an immune response in the body. So it will take some learning about which ones are specific. I'm not going to take you quite to that level. The next one are the selective adhesion molecule inhibitor drugs. These are also known as integrin antagonists or integrin inhibitors. They block a chemical called integrin, which will normally help leukocytes come into a damaged area and cause inflammation. So again, these are going to stop inflammation. These are also monoclonal antibody drugs. Unfortunately, I couldn't find a really nice American version, but I wanted you to see that these are injectable, and this was the best injectable image I could get. This is vedolizumab, and again, it's ending in that MAB, and these are known as Entyvio. And you've probably heard this TV commercial. I've got it ringing in my head right now. Entyvio, Entyvio, Entyvio. Right? I can't sing. I know. But maybe now you have that song in your head from those TV commercials. And that's used for IBD. We also use it for other things like rheumatoid arthritis and things like that. So a lot of these immunomodulators have more than one job. Now, TNF inhibitors, again, these are adalimumab. This ends in MAB. A TNF inhibitor blocks tumor necrosing factor, which is a chemical that can cause inflammation. When it's working normally, it identifies and breaks down to blood cells and foreign cells in our body, and it does really good. But when it's not working properly and it becomes autoimmune, it starts attacking our own cells, even our joints, like with rheumatoid arthritis. So Humira can also be used for rheumatoid arthritis and other autoimmune disorders. Here we're talking about like Crohn's disease, and Hulio is another, and these are self-injectables. These are administered subcutaneous, so the patient can just inject themselves when their next dose is needed. Kept in the refrigerator. All right. Now, other IBD conditions include ulcerative colitis. So that doesn't sound very pretty, right? You've got sores, ulcers in your large intestine, and there's inflammation. So your 5-ASA, which ASA is one of the things about aspirin, it's a salicylate. It's an aminosalicylate. So it's kind of like anti-inflammatory. And then Janus-associated kinase, which we usually just call a JAK, a JAK inhibitor drug. Wherever you see these abbreviations, use them. You don't have to know the long, drawn-out words. In ulcerative colitis, they potentially can have open wounds in their large intestine. We also have fecal matter and bacteria, so it could get infected. So we want to help reduce the risk of infection and help get that waste product and those potential issues out of the way. So 5-amino-salicylic acid, or ASA drugs, are, like I said, they're related to aspirin. So one, if the patient's allergic to aspirin, they can't take this drug. But they decrease inflammation by blocking production of prostaglandins. Most of them are administered orally, but some, including mesalamine, could be administered rectally as a suppository or an enema. So the prototype that I have is mesalamine. Mesalamine has different brand names depending on the drug route. Asacol is an oral formulation. Pentasa is oral. Rowasa is an enema. And then most of it's going to be generic these days. It's been around for a really long time. So if they have more sores in the lower part of their GI system, in the colon, they would use an enema. If it's kind of in the beginning stages of the colon, in the ascending or the transverse, using an enema, it's not going to get all the way up there. So using something oral would be more of a benefit. The JAK inhibitors, Asacol, mesalamine, I'm looking for a drug stem, sulfasalazine, olsalazine, salazide. Some of them have the sala in there, mesalamine. Yeah, SA, I guess we'll go with the SALA is our drug stem for the 5 ASAs. And then when we've got our JAK inhibitors, these end in citinib. So these work by blocking a specific enzyme known as kinase, Janus-associated kinase. We know enzymes because they end in ACE. So this is blocking a specific type of enzyme. And we're going to use that citinib as our citinib as our drug stem. So tofacitinib is Xeljanz, another one that I hear on TV all the time. And then this is what the bottles would look like. Now we do see that it comes in an immediate release or a regular release, and it comes in as an extended release. The next area that we're going to go through are drugs for IBS, or irritable bowel syndrome. So there's a number of different drugs, and there's a number of different things that's going on. So with IBS, sometimes patients will have diarrhea, and some patients could have constipation. But IBS is kind of triggered by emotional stress. That term is called exacerbated when it gets triggered and we have flare-ups. Sometimes we will use other drugs to reduce the stress or anxiety, like a benzodiazepine. That's not going to treat the IBS, that's going to treat the trigger. So we're not really talking about that here. So let's look at these drugs and put them in groups of what they're treating. So it's not necessarily exactly how your book has it laid out, but I figured we'll put them into what they're doing. So if somebody has IBS-D, that means they have IBS with diarrhea. And the first class are the anti-infectives. So when you have food intoxication or food poisoning, bacteria in the digestive system have waste products themselves called endotoxins that cause irritation in the intestine. And then using an anti-infective drug will help treat that bacterial infection and kind of stop the diarrhea that's a result of those endotoxins. So we have rifiximab here, rifaximin. I need to look, and I was looking over at the book because I'm trying to make sure that I'm covering all the stuff here for you and make sure I'm hitting all the highlights. And I looked away just at the wrong place. So it's rifaximin, and it's Xifaxan is the name. So this is an anti-infective drug. And then we also use antispasmodics. So in diarrhea, sometimes you feel the cramping as your intestines are kind of cramping and pushing things out. So if we can stop that, spasms in your abdomen, and slow down what's working. Now, this drug is technically an anticholinergic. It's going to block acetylcholine, which is the neurotransmitter that causes muscle contraction. Dicyclamin is the generic name, and it used to be known by the brand name Bentyl. A doctor may still refer to it as Bentyl. Tablets are the most common form. Continuing on with drugs that are used for IBS-D, opioid receptor agonist drugs. So these are going to activate the opioid receptor. Now, opioids, narcotics, actually have the side effect of constipation. So they're going to slow down the GI system. With diarrhea, if we slow it down, it's going to help absorb more water and reverse the effects, so there's not diarrhea. So in IBS, we use this opioid receptor. This isn't a narcotic, but it's kind of activating the same receptors in the GI system. So it's going to kind of dry things out. So we use this for IBS-D. This drug is, make sure I got the right one here. It is Alixodulin, and it's Viberzi is the brand name. And then we have the 5-HT3, a different serotonin receptor blocker drug. Well, no, it's not. It's a Cetron. But it is. It's working differently. It's working actually in the stomach. So, yes, it ends in Cetron. Most our Cetrons are being used for nausea and vomiting, but this is Lotranex. This one is actually for IBS-D. And it's slowing down that peristalsis. So there's that drug stem Cetron because it's a 5-HT blocker or antagonist. And then we have what are considered to be other drugs, antidepressant drugs like amitriptyline or the anti-infective drug that we've already talked about. I don't know why your book duplicated that. But then we also have combination drugs. Combination drugs may have a combination of an antispasmodic with an anticholinergic, along with an anti-anxiety drug or a barbiturate, a sedative. And your book lists out the different types of drugs that could be used for that. Donatol is one of the drugs that has atropine, which is an anticholinergic, hycosamine, which is an anticholinergic, antispasmodic, scopolamine, which is an anti-cholinergic, and then phenobarbital, which slows everything down. It's a CNS depressant. So lots of different things to stop the diarrhea. And then we have IBS with C, which means irritable bowel syndrome, with constipation. So diarrhea, you're going too much. Constipation, you're not going often enough. Things are getting backed up. So we want things to get back into motion. Let's move this stuff through. So we're going to start with these drugs. And like I said, I've changed the order that they're being laid out in your book because it made more sense to me to group them together by is it for diarrhea or constipation. So when we talk about drugs for IBS-C, we use chloride channel activator drugs. Here we have Amtiza, which is lubiprostone. So this is actually a prostaglandin agonist drug as well. And it works by bringing in fluid to soften up the stool and get it moving through. The next group of drugs that we use to treat the constipation are GCC agonists. They bind to a specific enzyme known as GC-C. It causes secretion of chloride, bicarbonate, and fluids into the intestines. Again, it's going to bring in that fluid with those, and it's going to kind of soften things up and get things moving again. These are going to pop back up again, potentially when we talk about the laxatives. We also have serotonin receptor agonist drugs. These are 5-HT4 agonists, so these are going to activate. The other ones we've talked about so far are blocking, so they slow things down. This is going to speed things up. If they have constipation, we want to get stuff going. These activate the receptors in the nerves around the intestines, increasing secretions and increasing movement in the intestines. So these are effective. This is Tegaserad, which is known as Zelnorm. The next ones are the sodium NHE3 inhibitors. Now, sodium Na is the elemental symbol for sodium, so sometimes it'll be Na-NHE3. These increase fluid into the intestinal secretions, increase peristalsis, and this drug is Tenapanor, which is Ibsrela, and the first part of that brand name is IBS. So it kind of gives you a clue there of what it's being used for. Now, those two larger groups, IBS, one for constipation, one for diarrhea. Now we're going to talk about just general diarrhea. What a lovely topic, right? So diarrhea, by definition, is a loose liquid stool. Again, concerns long-term, patients can become dehydrated. Most patients will have what's known as self-limiting diarrhea, which may not require treatment. But there's different ways to treat diarrhea, and usually we'll determine what caused it, and then we'll pick the proper treatment. Again, if it's from an infection, we don't want to slow things down in the body because then the infection could linger even longer. So it may be, maybe we just need to slow things down for water to be reabsorbed. So the main drugs that we're going to use to treat most types of diarrhea, non-infectious, anticholinergic drugs. Now, if it's from an infection, we're going to use an anti-infective drug or something that will bind to the chemicals of the infection. We also can use chloride channel regulators and opioid drugs. So we've already talked about some of those. So in antidiarrheals, we have anticholinergics. These slow the peristalsis or the movement, and these are classified as anticholinergic. They block acetylcholine. The class of drug is also sometimes referred to as an antimotility agent. Loperamide is one of the drugs. This is known as Imodium. In the over-the-counter, it's Imodium AD for antidiarrheal. It does come in a lot of different dose forms. Here we've got some gel caps. It comes like in a chewable. It comes in a liquid form. It comes in a variety of different forms. Now, the side effects of your anticholinergics, dry mouth, urinary retention, constipation, which is actually kind of, we're trying to dry out the diarrhea, so they shouldn't get to that end unless they've overdosed, blurred vision, and some can cause them to be drowsy. Now, if it's caused by an infection or something infectious, like food poisoning, we would use an anti-infective drug, something like bismuth subsalicylate, Pepto-Bismol, bismuth. They match up pretty well. This is going to cling to the bacteria in their waste products, and it's going to coat the stomach and protect it, and coat the intestines and protect it. So it's kind of helpful. This does not get absorbed mostly. It mostly will go out through your GI system. We do have to be concerned if somebody's allergic to aspirin because we've got salicylate here. So that might be just a little note that you need to be aware of. This is what's known as an adsorbent. Think like adhesive tape. It's going to stick to or cling to the infectious agent and help carry it out. Now, do note that antimotility drugs are contraindicated in treating infectious diarrhea because, again, we don't want Imodium if somebody's got infectious diarrhea because that Imodium is going to slow things down and that bacteria is going to stay in your system and keep causing trouble. So then it could become very serious. So knowing what the cause of diarrhea is can be important for the proper treatment. Other antidiarrheal agents, chloride channel regulators, we already talked about one previously when we were talking about IBS, but here they have listed crofelemer, which is Mytesi. And again, it's going to bring in fluid. It's going to attract water. Now, most often this is going to be used in, or I'm sorry, it's going to slow down, not bring in. It's going to regulate the loss of fluid. We use it in treating diarrhea associated with HIV. And then opioid drugs. Opioids slow everything down. And those mu receptors in the intestines slow down, and we get so paregoric, which is related to opium, is a drug that we could use for diarrhea. We do use some combination drugs that are related to narcotics. So diphenoxylate with atropine. This is Lomotil, low motility, slow it down. This is a C5 drug. So it is a controlled substance. It is a prescription. And then we also have diphenoxin with atropine. This is Modafinil. This is a C4 drug. Now, diphenoxylate and diphenoxin are related to narcotics. Both of these have atropine as their secondary drug. Atropine is an anticholinergic drug. So that's going to dry things out, urinary retention, constipation, blurred vision. And then, of course, we've got drowsiness because they're related to narcotics. So we can group them all together to get those side effects. Next, are the anticholinergic or antiflatulent drugs. So already talked a minute about simethicone. Simethicone is used to reduce gas. It comes in many different formulations. Chewable. It could be drops, especially babies who have too much air in their tummy. We have simethicone drops. So Gas X, the brand name's telling us it's blocking gas. Or Phazyme, it's going to kind of break down the bubbles. And I like how they're actually pictured here on the box. And then we have laxative drugs. So there's lots of different kinds of laxatives. Again, what's the reason for the constipation? Do we need to get things moving really quickly? Can we kind of take our time and get things kind of moving along? What's going on? So we have bulk forming, chloride channel activators. We have the CG-C agonists. We have irritant or stimulant laxatives, lubricant laxatives, opioid antagonists. Opioids are going to slow things down. If we block that, they're going to speed back up. Osmotic laxatives, 5-HT4 agonists, and stool softeners. So constipation is when the bowel movements are infrequent or hard to pass. Complications include hernias, hemorrhoids, and rectal fissures. And when patients are properly hydrated or have adequate dietary fiber, if they remain active, they're less likely to experience constipation. So drugs that we use to treat constipation, they're all known as laxatives, and most of them should only be used short term. The exception would be bulk forming laxatives. People might use fiber every day, and that's what a bulk forming laxative is. So let's look at them. So again, laxatives, we're using these to treat constipation. The first one being the bulk forming laxatives. This is an indigestible dietary fiber. The fiber absorbs water. It gives bulk to the feces. It makes things move much more easily. Then we have chloride channel activator drugs. We've already talked about Amteza. It's going to bring fluid into the stool to soften it. So we use this, and most often we're going to use this, the chloride activator to treat IBS-C. We have this GC-C agonist, which I also just talked about. I did not talk about Linzess. Did I talk about Linzess? I'm thinking I didn't, but I know I talked about a GC-C agonist. This is linaclotide. This is Linzess. It causes secretion of, I did talk about these. It softens the stool. And we use it for IBS-D. It's been a minute. That's why I already forgot. Then we have irritant or stimulant laxatives. These are going to kind of cause irritation in the intestine. And if you think, maybe you had a little brother or little sister growing up and they irritated you and you just kind of wanted to push them out of the way, right? As a kid, they were just irritated and you just needed to get it away from you. That's kind of how an irritant laxative works. It's going to irritate the intestinal lining and just push things out so that it's not as irritating. So your book uses this image, Dulcolax. The drug is Bisacodyl. So Bisacodyl is the generic and Dulcolax is the brand. But I'm going to caution you because there are other brand name Dulcolax that are not Bisacodyl. So you have to read the actual label to make sure that we know what it is. Now it's saying gentle and predictable. But I'll be honest, sometimes these do cause cramping because these are stimulants. They're kind of irritants. These can also be known as cathartics or purgatives, and cramping is one of their main side effects. Next, we have lubricant laxative drugs. These bring in oil or water to help soften the stool. So Fleet enema. This is a liquid form. It's inserted rectally. And this one over here is a saline laxative, where this one is actually a mineral oil. So saline's going to ask water. It's going to kind of break things down, where mineral oil is going to lubricate and make things more slippery. And then we have the opioid antagonist. So we're going to block the opiate from causing the slowdown. So things move up. And we have want to make sure I say this properly, naloxegol, which is Movantik, another TV commercial that I hear a lot. For, again, sometimes we use this for opioid-induced constipation. So this would be if somebody's on long-term use for chronic pain, they're using opiates, they might be given a prescription for Movantik to help keep things moving on the regular. The next group are your osmotic laxatives. Osmotics pull water into the bowel to soften it. Lactulose is one of them. This is an interesting one because here we see a lot of oral, and then these are what's known as a unit dose. And we see that there's different strengths here, so we want to be aware of that, whatever the patient's needing. This is a weird one because it can also be administered rectally, and it's the exact same drug. So, and then we have polyethylene glycol 3350. This is called Miralax for laxative. So they're going to bring fluid in. And then we have 5-HT4 receptor agonist. And this is procalamide. Sorry, I looked away again. Prucalopride. Make sure I say that right. This is Motegrity. So again, we've got that movement kind of thing. We also use these drugs in treating IBS-C. They will activate, these are agonists, the 5-HT4 receptors, but they do have an adverse effect of increasing risk of suicidal thoughts and behaviors. So when the patient, if they're given this medication, they will also receive what's known as a medication guide. The 5-HT4 receptors found in the intestines, they're going to stimulate those receptors and increase secretions and peristalsis. And then we have our stool softeners. Now, these are going to be the most mild. They mix fat and water into the stool to soften it. So before I told you we had that Dulcolax that was Bisacodyl. Well, this Dulcolax is not Bisacodyl. This Dulcolax is Docusate. It is a stool softener, and this one is Docusate. So they both have the same brand name, but it's actually different ingredients. So you've really got to be careful about reading those labels. Colace is the more common brand name for Docusate. Don't call for these stat, right? Stat needs, you need it right away. This is going to take about 24 hours before it really starts working. So it's not going to work very quickly. Then we have combination drugs. So mixing things, this combination is a combination of a stimulant laxative and a stool softener. So when we're looking at these, we have Senokot. This is Senokot S. It's got Docusate in there, and then it's got Sena, or your book refers to it as a Senocide. So Sena is going to be your stimulant, and the Docusate is your stool softener. Okay, we're starting to get a little bit closer to the end here. Thanks for bearing with me. I know this is a little bit long. I did attend a conference just this weekend that's kind of helped me with some ways to maybe change the approach to some of my slides and make it a little quicker to get through the material. Drugs for hemorrhoids. So hemorrhoids can be a complication of constipation. For every force, there is an equal and opposite force. This is basically varicose veins in the anal area. They can be internal or external. They can itch. They can actually rupture and bleed. So they can become a potential area for infection. But pain and itching are the most common symptoms. Treatment, we want to reduce the size of the blood vessel with anti-inflammatory agents or vasoconstrictors, and we want to reduce the pain and itching, and we can use local anesthetics to do that. Hemorrhoids, they're swollen, protruding veins in the rectum. They could be internal or external. They could be in the skin around the anus. And like I said, most commonly it's going to be from constipation. It could be from obesity, pregnancy, things that are going to put stress on the lower part of the body, sitting too much. Many different drugs can be used to treat. We use topical drugs, including corticosteroids. So here I have hydrocortisone cream. They also come in a lot of different dose forms. We have anesthetics. Here we've got Proctofoam. So foam's another. This is also hydrocortisone. Preparation H. This is also going to be a steroid. This is in a gel form. Americain. This is an ointment, but it ends in cane. That is a local anesthetic. It's benzocaine. So like benzocaine, tetracaine, lidocaine, those are anesthetics. Those can be very beneficial. We have Anusol, which is a suppository. This is going to be a steroid. And then we have things like Tux pads, which is actually witch hazel, which is an astringent, which shrinks the blood vessels. So lots of different dose forms. Is it an internal? Is it an external? Stop the itching, stop the inflammation, shrink the blood vessels. We can do lots of different things in treating those hemorrhoids. The next group of drugs are drugs that we use for treating obesity. These are to help patients lose weight. So drugs will either work to suppress appetite or they're going to impair the absorption of dietary fats. So the term anorexant is a term that means a drug that will suppress the appetite or stop your hunger. And then we'll look at some of the other drugs that can do that as well. So anorexant drugs, like I said, these are appetite suppressants. They're similar in their chemistry to amphetamines, but with a lower incident of addiction. So where most amphetamines, which also can be used for weight loss, like dextroamphetamine, Dexedrine, those are C2s, but these drugs are C3s and C4s. So the two that are tied most closely to your drug worksheet, phentermine, Adipex P, that's a C4, and then Lumira is also a C4. Other drugs that are in this group include benzphentamine, which is Didrex, that is a C3, diethylpropion, that is a C4, and phendimetrazine, which is Bontril, which is also a C3. Ones that are in the news a lot these days are the GLP-1 receptor agonist drugs. GLP stands for glucagon-like peptide, and there's a specific one, which is number 1. This is a drug that activates the GLP receptor, and it slows the emptying of the stomach, which leaves the patient feeling more full. It also activates receptors for glucagon-like peptide, GLP-1, which is the appetite regulator in the brain. These drugs are administered subcutaneously. These started out as drugs that were being used to treat type 2 diabetes, but it was found that weight loss was another indication. So the drug semaglutide is sold as Wegovy for weight loss. We hear a lot about this in the news. There's been a lot of shortages, which can be detrimental to patients who need this drug to treat type 2 diabetes. Now, just a note, because patients are like, ooh, this is kind of like the magic shot. One of the challenges, if a patient is using semaglutide to lose weight, they will need to remain on this drug to maintain that weight loss. So it's not once you meet your target weight, you can stop taking it. Patients who've stopped taking it, many of them have actually put on more weight than they lost. Next, we have melanocortin receptor agonist drugs. These stimulate receptors in the brain that control your hunger and your feeling of fullness, satiety. So this drug is given subcutaneously. It's an injectable drug, not overly commonly given, but it is out there. And then we have combination drugs. So these contain an anorexic, the drug phentermine, as well as an antidepressant drug, bupropion, and or an anti-seizure drug, topiramate, or it could be an opioid antagonist like naltrexone. Now, naltrexone will block the release of endorphins, the chemicals that make you feel good when you eat sugars and fats. So it's going to kind of block that feeling. So the one that I selected for your drug list is a combination of phentermine and topiramate, and this is known as Qsimi. This is a controlled substance. Now, those classes of drugs are going to help reduce your appetite. This drug is a lipase inhibitor. So what a lipase inhibitor does is it stops the enzyme that breaks down fats during digestion and allows them to be absorbed. So it's going to leave the fats in your GI system, so they're not going to be absorbed into your body where they could be turned into sugar and then fat stores. So a lipase inhibitor, the drug is Orlistat. It's sold over the counter by the brand name of Ally or Alley, and it's also sold by prescription under the brand name of Xenical. So some challenges with this because the fat is not being broken down and it's going out the digestive system. Some people have fatty stool and leakage should they pass gas. So people need to be aware of that. It's not a very pleasant side effect. We're going to talk now about accessory organs of the GI system. So the main accessory organ that we're going to talk about, there's two. We're going to talk about the liver and we're going to talk about the pancreas. So with the liver, conditions that affect the liver include hepatitis. So the term hepatitis means inflammation of the liver. And there's many different types of hepatitis. There's hepatitis A, hepatitis B, hepatitis C. For hepatitis A and hepatitis B, there are actually vaccines. And as a healthcare worker, most facilities are going to require that you have the hepatitis B series. That's going to protect you from bloodborne pathogens and contracting hepatitis B. Now, hepatitis B or C can turn into chronic hepatitis, so we have drugs that will treat them. Generally, hepatitis is caused by a virus, so we're going to use drugs that are going to help combat the virus. Okay, so the drugs that we're going to use for hepatitis B or C. Interferon drugs. Interferon slows production of hepatitis virus, and it also helps to stimulate the immune response. Our body produces interferon to protect itself from viruses. So this is going to give a bump up to our immune system. PEG interferon alpha 2A is known as PEGASIS. So you think, okay, you got PEG interferon, and the brand name starts with PEG, and it's getting an assist, PEGASIS. This is given subcutaneously. We have NS3-4A and NS5A and NS5B inhibitor drugs. A lot of numbers, a lot of letters. These are actually protease or polymerase inhibitors. These are related to drugs used for HIV. So Sofosbuvir is Sovaldi, and what it's going to do is it's going to inhibit the viral replication. So therefore, the virus can't survive. It can't continue to do damage. Other drugs for hepatitis B or C, these are also drugs that are used in treating HIV. Nucleoside reverse transcriptase inhibitor drugs. It's a lot to remember. We generally just abbreviate that NRTIs. Lamivudine is Epivir, and on this brand name, this one is specific for treating hepatitis B virus, and it's on the label. We also use nucleotide. So NRTI is nucleoside, and TRTI is nucleotide reverse transcriptase inhibitors. This is Adenavir, and the brand name is Hepcira. It's for hepatitis. This restricts the viral enzyme to reverse transcriptase. So both of these, one of the things about HIV, and we'll get to that later in the semester, these are what are known as retrovirals. So the way that they duplicate their DNA strand is different than most viruses. So this is disrupting how the virus is producing its cloning or regenerating its DNA particles for a very short, basic way to approach that. Then we also have combination drugs. So this is a combination of sofosbuvir and ledipasvir, and it's called Harvoni. Some of these are also used in treating HIV, which Harvoni might be used also in PrEP. They may be under a different name for the lamivudine and the adefovir. Close to the liver is the gallbladder. So the gallbladder, one of the challenges with the gallbladder is having gallstones. So cholelithiasis is the presence of gallstones, and cholecystitis is inflammation of the gallbladder. And evidently I didn't do a good job on my animations for this slide, so I'm just going to bring up the whole headings. So the first drug is a bile acid drug. So cholesterol, which is made in the liver, is used to make bile. Bile is needed in digestion. Bile is stored in our gallbladder. So if something goes wrong, kind of like kidney stones, we can get gallstones. Bile acid drugs are going to decrease the production of cholesterol, which decreases the formation of gallbladder stones. So ursodeoxycholic is known by the brand name of Actigall, and it's got gall in there like gallbladder. And then we also have antispasmodic drugs, which are anticholinergic drugs. And these help because they decrease the spasms, which can cause pain of the smooth muscle of the gallbladder. If you've got stones in there, it can irritate and then it can spasm and it can be very painful. So this is going to decrease bladder contraction, spasms, and what's known as biliary colic. This drug is hycosamine, hycosamine, and it's known as anaspaz, so it means without spasm. Anaspaz. And next we come to the pancreas. So this is actually our last slide of drugs. So drugs for pancreatic insufficiency. So there's lots of different reasons why the pancreas doesn't work properly or give us the right enzymes. And we need pancreatic enzymes to digest our foods properly. So there's different ones. We have lipase. Lipase breaks down fats. We have amylase. Amylase breaks down carbohydrates, and protease breaks down proteins. So the food, it gets sprayed with these enzymes that come out of our pancreas, and then we can break it down, we can absorb the nutrients, and they can be used in our body. One of the most common reasons for pancreatic insufficiency is a condition known as cystic fibrosis, or CF. It's a genetic condition. People are born with it, so it's congenital. They produce a very thick, viscous mucus in their body. It also affects the respiratory system, but it causes a deficiency in these pancreatic enzymes. So they have to take pancreolipase to replace what's missing so that they can properly digest food and get nutrients. So amylase, lipase, and protease, they're all in different combinations in these drugs. So we have to be careful to make sure we're picking the correct mix. So pancrease with a Z is one of the brand names, and then Creon is one of the common brand names as well. All right, now it's time for questions.